Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a woman of 39 years of age, smoker and diagnosed of antiphospholipid syndrome, who is transferred to our unit with the diagnosis of a 3 hours of evolution STEMI. At her arrival, she remains stable, although chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it. In this electrocardiogram, the first of some that were performed before cardiac catheterization, a broad elevation of the ST segment is evident in precordial leads and also a simultaneous and discrete elevation of the ST in the lateral wall. Besides, there are hyperacute T waves from V2 to V4 with poor progression of the R wave in precordial leads, which suggest an early character of the findings. In this other electrocardiogram, made immediately before entering the room, it is clear that the ST elevation is persistent, but there can also be seen that the R waves have been cut off in the majority of leads, appearing Q waves and QS complexes in the majority of the leads. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, cardiac catheterization was performed, and as you can see, the right coronary artery is open, its development is short, and it does not have significant lesions. Let's take a look now at the left coronary tree. As you know, the left coronary tree bifurcates into two branches, the circumflex and the anterior descending artery. So, we can see that the circumflex is a great caliber blood vessel and of good development that is also permeable, and it does not present angiographically significant lesions. In this way, it is important to point out that the circumflex presents three big marginal branches and a posterior interventricular branch, motives for which we can say without fear of erring that this patient presents a left coronary dominance. For its part, and regarding the anterior descending artery, it is clear that it is obstructed at its proximal level, which explains the electrocardiographic changes previously described. Now we know where the obstruction is and we only need to treat it. First thing to do is to pass an angioplasty guide wire through the closure. Sometimes, as in this case, passing the guide wire partially opens the artery and allows us to see part of the distal bed. In this case, the next step was to implant a stent on the blockage zone. This props the artery and returns blood flow. And this is the final result. As you can see, we have recovered the flow of the artery after the implantation of the stent, but we have not achieved a good angiographic result because, as you can observe, there is a significant disproportion of the caliber between the artery and the proximal portion of the stent. However, in this occasion, it was decided to postpone the post-dilation of the stent for another moment because the risk of suffering a no-reflow complication was present. After a couple of days and after an optimal antithrombotic treatment, the patient returned to the cath lab with the objective of studying the result obtained with an intracoronary image technique, in this case an OCT or optical coherence tomography. As you can see, this diagnostic tool allows us to see a superposition of axial cuts of the coronary vessel, allowing us to see the interior of the studied vascular segment from distal to proximal. So it was easy to confirm what was already evident in the angiography. the malposition of the implanted stent, a problem that could trigger, for example, a thrombosis of the device if it was not corrected. After choosing a non-compliant balloon of an adequate diameter, post-dilation of the stent is performed. We then perform an angiographical control and, right after, a control OCT. As you can see, the problem is corrected because the sequence now shows a stent well apposed and well expanded. In this way, with the artery open and with the technical problems of the stent corrected, the patient evolves favorably, reasons for which she is transferred to the hospitalization unit. In the control electrocardiogram, we can see the natural evolution of the disease because, as you see, the ST elevation has practically disappeared, the T waves have become negative, and the Q waves are still present. With this, we say goodbye. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!